So again, welcome everyone to our first of three presentations about responsible diagnostic testing and antibiotic use in the management of common infectious syndromes in skilled nursing facilities. Just to lay out our objectives for the session today, we're going to talk about how to recognize the signs and symptoms of suspected respiratory tract infections and the differentiation between some of the common respiratory infectious syndromes you're likely to encounter in your residence. We're going to talk about the indications for antibiotics versus supportive care alone for residents who are complaining of a cough. And we're going to talk about how to recognize some other syndromes, both infectious and non-infectious, that can be confused with acute bacterial pneumonia, but would not benefit from the addition of antibiotics. After that, we're going to review some testing recommendations and empiric treatment options for patients with suspected or confirmed pneumonia, and talk about some opportunities to de-escalate antibiotic therapy using the results of diagnostic tests and patients' clinical responses. And we're also going to talk about reasonable durations of antibiotic therapy for pneumonia for our long-term care facility residents. Just some brief disclaimers. So all these materials were provided by the AHRQ, but do not necessarily represent an official position, policy position of the AHRQ or of the Department of Health and Human Services. And of course, all of the information here is for your consideration. Our goal is to inform, but never to supersede your own clinical judgment when it comes to providing care for the patient in front of you. So first, let's talk a little bit about assessing a resident with a suspected respiratory tract infection. First, we'll start with defining some of the terms that I'm going to be using for the duration of the presentation. There are many different types of respiratory tract infections that you're likely to encounter in a skilled nursing facility setting. So first, we have the common cold. Typically, when we talk about this, we are talking about an upper respiratory tract infection that is involving the sinuses, the oropharynx, but not the lungs or lower airways. That is caused by a variety of different respiratory viruses. Patients with colds can have symptoms for up to 2 weeks. But the mainstay of treatment for these folks is going to be supportive care, rest, fluids, analgesics, mucolytics, etc., and close monitoring as we wait for their symptoms to resolve. You're also likely to encounter acute bronchitis. This is a lower respiratory tract infection or other inflammation of the bronchi, the large airways in the lungs. The majority of bronchitis, about 90%, is caused by viruses, not bacteria. And therefore, patients with bronchitis generally will not benefit from the addition of antibiotics. It's important to talk about this because it can be challenging to distinguish bronchitis and pneumonia clinically. We'll talk about some ways to do that a bit later in the presentation. But the management of these conditions is typically going to be quite different. Influenza, as I have no doubt everyone here is aware, is a very important respiratory virus that can cause a spectrum of respiratory illnesses. It is typically a seasonal virus, most common from October through March, but it's important to keep in mind that flu infections can happen year-round. In fact, just yesterday, I had a call with a physician in the ED about a patient coming in with a new diagnosis of flu, particularly in long-term care settings and acute care settings where you have a lot of folks staying in close proximity to each other. It's important to have a high degree of clinical suspicion. And of course, the best way to prevent influenza, both for an individual patient and when we're talking about outbreaks within a facility, is to have a program in place to require or at least strongly encourage routine annual vaccination for residents and staff. And of course, we're also going to spend a lot of time talking about pneumonia, which refers to inflammation of the actual lung tissue, not just the airways as in bronchitis. This can be non-infectious. When we're talking about infection, about 75% of the time, pneumonia will be caused about bacteria and will be caused by bacteria and will require antibiotic treatment. About a quarter of the time, though, pneumonia can be caused by viruses, including influenza, especially including COVID-19, which I'm not really going to talk about much. It's a little outside the scope of this presentation. But certainly that's an important viral cause of pneumonia in this day and age. It has a spectrum of clinical presentations, but an important part of diagnosis is going to be interpreting chest x-rays, which we'll talk a little bit more about in a bit. So this diagram just sort of illustrates visually some of those infectious syndromes I was talking about on the last slide. Here you can see sinusitis, the common cold, and laryngitis are upper respiratory tract, typically viral infections that you're likely to encounter in a long-term care facility setting. Strep throat, as distinguished from these others, is a bacterial infection caused by group A streptococcus. It does require and should be treated with antibiotics to help reduce the risk of post-infectious complications. Typically, this is going to be diagnosed with a rapid throat swab test and or a throat culture. And then here at the bottom, we have our lower respiratory tract infections. Bronchitis, again, inflammation of the airways, typically viral, versus pneumonia, inflammation of the actual lung tissue, and typically caused by bacterial infections. So let's move on to discussing some cases. First, we have the case of Sandy. She is a 75-year-old woman living at your facility who has moderate dementia and congestive heart failure. She's also wheelchair bound at baseline. So she tells you that for the past 2 days, she's been feeling very tired and fatigued. She feels congested, achy, both her head and all over her body. And she's also been coughing, bringing up some yellow phlegm. You also know that last week, her family came to visit her for Christmas. So we're now in December, let's all pretend. And during that visit, you find out that her granddaughter had been coughing quite a bit. So when you go to see her, she has a temperature of 99.8, so a low grade temp, normal heart rate and blood pressure, normal respiratory rate, and a pulse ox of 96% on room air. On exam, she looks congested, her nose is running, her eyes are red. However, she looks to be breathing comfortably and her lungs sound clear on exam. So, using the polling function, what would be the next best step in management for Sandy? Do we want to test her for influenza, start antibiotics, do some additional workup with urinalysis, urine culture, and chest x-ray? Or do we want to just sort of manage her symptoms, bring her some ice cream and something to help her sleep? I'll give a minute or two for folks to answer via the polling function. I hope the poll's working. Okay, so everyone agreed that we should test Sandy for influenza, which is the right answer. So we have a patient presenting in the middle of flu season with respiratory symptoms, fever, and other clinical findings that would go along with this diagnosis. It's really important for us to test her, not only so that we can manage her, but so that we can manage the risk for other patients at the facility. So for a patient presenting within at least 4 days of symptoms, but particularly within 2 days of symptoms, treatment with Tamiflu at a standard dose of 75 milligrams orally twice a day for at least 5 days has been shown to reduce the length and severity of symptoms. It's also very important to isolate Sandy in this situation. She'll need to be placed on standard and droplet precautions, and her roommate and any other close contacts should be tested and potentially prophylaxed. In this case, no one chose any of the other responses, but just to sort of review why they're not the best choice for the time being. At this point, she's not complaining of any urinary symptoms, and we have an alternate explanation for her fever in the form of her respiratory infection. So we don't really need the urine studies. At this point, she also has a clear lung exam, and she's breathing comfortably, not requiring supplemental oxygen. So the chest x-ray might not add much information, although if she gets worse, certainly this may need to be something we revisit. Since we are suspicious that she has the flu, or at least another respiratory viral infection, there's no need for antibiotics at the moment. And we don't want to jump straight to supportive care without ruling out flu for the reasons I just discussed, not making sure that we're treating her and isolating her appropriately. So in this case, we send the flu swab and it does come back positive for flu A. This is just reviewing some of the suggested next steps that I mentioned before. We want to treat her with oseltamivir, Tamiflu, as she's presenting very early in her symptom onset and is likely to get some benefit from it. Make sure that we isolate her appropriately, test roommates and any other close contacts. And again, just to reiterate, it's important that residents in the facility are vaccinated, or at least offered and encouraged annual flu vaccination to reduce the risk of any outbreaks in the future. Moving on to our next case, we have a 73-year-old gentleman with a 50-pack-year smoking history, currently smoking up to this day, who also has a history of diabetes. Unlike our last resident, he's been here for a relatively short time for intensive physical therapy as he's recovering from a recent hospitalization for a stroke. He's been doing very well with therapy, and so he recently went home for the weekend for a visit. But 2 days after coming back, he reports that he's just feeling crummy, very tired and fatigued. He's developed a cough with some green sputum production, and he has a scratchy chest pain or discomfort whenever he coughs or he takes deep breath. And you also notice that he hasn't gone outside to smoke all day, which is definitely a significant change in behavior for him. On examination, his temperature is 99.4, heart rate of 96, blood pressure of 102/66. His respiratory rate is a little high at 22, and his oxygen saturation is 95% on room air, but this is pretty typical for him, not too different from his baseline. So you examine him further and notice that he's coughing up dark green sputum all throughout the examination, and he also has some wheezes in both of his lungs when you listen on exam. So for our next polling question, what should be our next step for this resident? Do we want to start him on levofloxacin for 10 days to treat him for pneumonia? Do we want to give him some supportive care? Or do we want to talk to the nearest emergency department? Again, I'll give about a minute. Okay, so we have a bit of a split, a response for supportive care and close monitoring, and a response for contacting the nearest emergency department for admission. So in this case, the answer that we're going for is number 2. Supportive care, recommend that he continue to avoid smoking while he recovers from his illness, and close monitoring. So at this point, he's hemodynamically stable. His respiratory status is not significantly changed from his baseline. He doesn't necessarily need to be admitted to the hospital yet. But, as the choice number 3 indicates, he is certainly someone who is at risk for disease progression. And that's why it's very important to keep a close eye on him, make sure that his respiratory status is not worsening, he's not becoming hypoxic or septic. At that point, we would need to think about transferring him to the emergency room. And no one chose answer number 1, levofloxacin for 10 days, which is great. At this point, we don't have any clear evidence for a diagnosis of pneumonia. And even if we did, 10 days of levofloxacin may not be the best choice. We'll talk more about that later in the presentation. So in this case, we manage his symptoms, we keep an eye on him, and when we check in on him 5 days later, he says that overall he's feeling a bit better, but he still has this nagging cough that's just not going away. So at this point, what should we do next? Do we want to get a set of vitals and assess him again? CBC and chest x-ray to look for evidence of pneumonia, or do we want to start him on antibiotics? I will acknowledge that this question is a little bit tricky, and a couple of these are arguably right. But what it would be sort of the first thing, best response of what to do next? Okay, so again, we have a split between vital signs and reassessing Jonas or getting a chest x-ray and a CBC. So this, I will admit this is a little tricky, so because answer 2 is not wrong, but this question is just trying to get to the heart of, in this situation, when you're deciding on what tests may or may not be indicated, an up-to-date physical assessment is always going to be sort of the go-to first step. Based on that, you very well may also decide to get a chest x-ray and a CBC, but the first step is going to be examining the patient, if you're able to. And no one chose answer number 3, which is exactly right. At this point, we still don't necessarily need to start antibiotics, but we do need to kind of check in and see if maybe things have changed with him. So just to review, stepping away from the case of Jonas for a little bit, to review some of the similarities and differences between acute bronchitis and pneumonia. It can be very challenging to differentiate between these two syndromes, particularly in elderly patients. So bronchitis, again, is a virtually always self-limited inflammation of the large airways in the lung, the bronchi, as opposed to pneumonia, which is inflammation or infection of the lung tissue, often does require some sort of treatment intervention in order to resolve. Bronchitis is greater 90% or more of the time is caused by a viral infection. There are a few bacteria that can cause bronchitis, however, most notably Bordetella pertussis, the same bacteria that causes whooping cough in newborns. That is, Bordetella bronchitis is the one exception to this generally self-limited rule that does frequently require treatment with antibiotics. In contrast, pneumonia is going to be caused by bacteria about 75% of the time. Around 25% of the time, it can be caused by viruses. Generally speaking, if you have a patient with pneumonia, you're likely going to treat with empiric antibiotics until you get a diagnostic test result that confirms the presence of a viral infection. The symptoms of bronchitis and pneumonia can be quite similar. Both will typically present with a cough, often a productive cough, present with fatigue and just general malaise. Patients with bronchitis may have a fever, although it's less common and typically lower grade than the degree of fever you would expect in a patient with a bacterial pneumonia. Patients with pneumonia also may present with chest wall pain or pleuritic pain. That's less common in bronchitis, but is not necessarily pathognomonic for pneumonia. When it comes to diagnostic test results, both patients may have an elevated white blood cell count, although typically in pneumonia, the elevation will be higher. And critically, a patient with acute bronchitis should not have any specific chest x-ray findings, whereas a patient with pneumonia, you would typically expect to see some acute change, a pulmonary infiltrate, and potentially pleural effusion, new compared to their baseline imaging. So in this case, we get a chest x-ray and a CBC for Jonas, and we find that he has a normal white blood cell count, and his chest x-ray doesn't show any acute changes that would fit with pneumonia. So in this case, what do you think is most likely going on with this resident? Is this acute bronchitis, influenza, pneumonia, or the common cold? Give it about 30 more seconds. Okay, so we have two responses here for the common cold. The answer that we're going for with this question is acute bronchitis. In this case, he does have wheezes on his lung exam, and he has a productive cough. Those things would fit with a lower respiratory tract infection like bronchitis. I think so. Definitely, when it comes to number 1 and number 4. This is most likely a viral infection similar to the common cold, but just affecting a different part of the respiratory tract. At this point, we don't have clear evidence of number 3 pneumonia because his chest x-ray is clear, and it would be very unlikely for him to have influenza with a negative flu test. The sensitivity for most of the commercially available tests nowadays is quite good. False negatives are uncommon. So in this case, we are going to manage this as a viral infection. We don't want to give him any antibiotics. So just to talk a little bit more about reviewing chest x-rays in skilled nursing facility residents, this can be very challenging in this population because it is very common for long-term care facility residents to have underlying lung abnormalities, structural lung disease, heart failure, etc. Depending on the resident's degree of functional impairment, it can also be really hard to get a good quality film, whether that's due to problems positioning or problems taking a deep breath, difficulty following the instructions of the X-ray tech. So it's very important in these situations to compare images to any prior chest x-rays you may have in order to help you differentiate what's a new finding versus what's an old finding. Just to illustrate the example, if you had a resident who was presenting with a new cough and you had this chest ray image on the right, you might say, oh, well, it looks like there's some haziness here at the right lung base. I see a left pleural effusion. Looks like this is a patient who may have pneumonia. But if you were then to go back and compare to this chest x-ray from 2 weeks ago, you would see, oh, actually, it looks like these findings are chronic. And there's nothing particularly that looks new on the new film compared to the old. And it would very much change the way that you interpret this new imaging. So going back once again to Jonas, you talk with him and his daughter about your diagnosis of bronchitis and how you don't want to start any antibiotics right now. And his daughter gets a little upset. She says, my dad's been coughing for a week. He doesn't feel good. Why can't you just give him some antibiotics to make the cough go away? I didn't make this a poll question because I think hopefully we would all agree that answer number one, just kind of giving in and saying, okay, we'll give him some antibiotics. And moreover, telling her that the antibiotics will make her dad better is not the right response. Because we think that Jonas has a viral infection. Antibiotics are not going to have an effect on, the course of his bronchitis. And in the worst case scenario, they put him at risk for side effects like allergic reactions or drug-drug interactions, potentially infections with more resistant bacteria down the line, or complications like C. diff infection. So we don't want to tell her something that's not true. Instead, it is good to use an approach that is a combination of number 2 and number 3. Talk with him and with her about the diagnosis of bronchitis, what that means, the fact that it's due to a virus over 90% of the time, and that in the vast majority of cases, it gets better on its own, although it can take some time, even a couple of weeks, to go back to normal. And to emphasize to her and to him that just because we're not giving antibiotics, it doesn't mean that we're not going to treat him. We're going to manage his symptoms with cough suppressants, breathing treatments, mucolytics to make him more comfortable. And we're also, importantly, going to be keeping a close eye on him so that if he's not continuing to get better the way we expect, we can reassess, make sure that he doesn't have some new infection like pneumonia or another process going on that explains why he's not getting better quickly. So moving on to our last case for the first part of the talk, we have an 83-year-old gentleman with a history of congestive heart failure who tells you that he's been feeling short of breath and coughing, just generally feeling poorly now for about 10 days. He feels just kind of tired and run down, but he hasn't been having any fevers or chills. He doesn't have any sinus congestion or any headache, no chest pain or muscle aches, but he is coughing quite a bit, and the cough is productive with a lot of clear sputum. You also find out from talking with him and his roommate that last night they ordered a delivery pizza and some wings, which they shared, and that earlier this week, he also ate a bag of potato chips while they were watching the football game together. So on examination, you find that he's afebrile, his heart rate is normal, but his blood pressure is quite high, 173/67. He's satting a normal 96% on room air. And when you examine him, you see that he looks comfortable. He does have crackles at the bases of both of his lungs. His abdomen is soft. He has symmetric 2+ lower extremity edema. And you decide to get a chest x-ray, which does show that he has bilateral lower lobe lung infiltrates. So based on the information we have right now, what seems to be most likely going on with this resident? Does he have a viral pneumonia because he's been feeling sick for about 10 days? Does he seem to have bronchitis, a heart failure exacerbation, or bacterial pneumonia? Give it a couple more seconds. Okay, so heart failure exacerbation. I agree. So taking this whole picture together, heart failure seems like the most likely explanation. We know that he has CHF. We know that he's been cheating on his low salt diet a little bit recently. And importantly, other than the cough, he doesn't really have any typical infectious symptoms. He has no sinusitis symptoms, no fever. It's a good thing to consider that patients can have more than one thing going on at once, and pulmonary edema does potentially put him at risk for developing a bacterial pneumonia. So it's important to monitor his response to diuretics, ensure he's getting better. If he's diuresing well, but he's not improving, then maybe he would warrant further workup for possible pneumonia. Maybe he would warrant empiric antibiotics. Maybe he would even need to be transferred to the hospital. But for now, we can sort of manage his heart failure and see how things go. So just some take-home points from the first part of our talk about assessing a resident presenting with a possible respiratory infection. It's important to keep in mind that the majority of upper respiratory tract infections, like the common cold, like sinusitis, are caused by viruses, and they don't require treatment with antibiotics, at least initially. You know, it's important to monitor these patients, ensure that their symptoms are improving, but empiric antibiotics are not generally going to be part of our upfront therapy. It's also important to keep in mind that during the winter months, flu season, any resident with a fever and cough should be tested for influenza. It has important implications not only for that particular resident, but for any roommates or other folks, both staff and residents at the facility who've been in close contact with them, in order to make sure that they're being treated appropriately and also to do whatever we can to prevent an outbreak. And at every point in the assessment of a resident with a suspected respiratory tract infection, it's important to maintain clear communication, not only between all the members of the care team, but also with the resident and with their family members, to make sure that everyone is on the same page about what treatment is being given and why, and just to emphasize that just because we're not giving antibiotics, that doesn't mean that we are not treating. You know, at every step of the way, we'll provide supportive measures as appropriate, and most importantly, actively monitor the patient for any concerning clinical changes. Moving on to the part of the talk about management, I'm going to start with a little bit of information about risk stratification when it comes to determining what sort of bacteria you should be concerned about and what sort of antibiotics you may want to offer a patient with suspected pneumonia. So it's good to keep in mind that a facility resident who's in generally good health with a suspected bacterial pneumonia is most likely going to be infected with most of the common community organisms, in particular Streptococcus pneumoniae, but to a lesser extent, Haemophilus influenzae. I think that it is a common idea that simply living in a skilled nursing facility or other long-term care facility increases someone's risk of having more resistant infections. That may be true to a small extent, but really the significant risk factors for pneumonia due to a resistant organism, in particular for infection with Pseudomonas aeruginosa, are going to be these factors here at the bottom of the slide. So not just living in a facility, but having been recently hospitalized in an acute care facility or being treated with broad spectrum antibiotics. By recently, I mean within the past 90 days. Of course, any resident who has a history of prior Pseudomonas infection is going to be at increased risk, as well as residents who have structural lung disease like bronchiectasis or who are tracheostomy or ventilator dependent. And of course, also residents who have some sort of immunocompromising position like a hematologic malignancy or an organ transplant or autoimmune disease that requires treatment with an immunocompromising medications. So for our first case of this section, let's talk about Mary. She is a 90-year-old woman with mild dementia, who's typically quite active, working with physical therapy, and at least semi-independent in most of her activities of daily living. She's never had any problems with swallowing. She's never had any known prior aspiration events. It is worth noting that about 2 weeks ago, she was treated for a suspected UTI with nitrofurantoin, and currently she's not having any urinary symptoms at all. So bringing us up to the present, her nurse notices that all night long she was coughing, and then the next day finds that she has a temperature of 99.2 Fahrenheit, and so obtains some additional information. So on exam, she does have this low-grade temp, normal heart rate and blood pressure. Her oxygen saturation is on the borderline 95% on room air, and she is tachypnic with a respiratory rate of 22 breaths a minute. She looks fatigued and is coughing through the exam, and she does have a focal lung finding of crackles at the base of her left lung. Because she looks unwell and she does have this abnormal lung exam, you decide to go ahead and get a chest x-ray, which does show there's a hazy infiltrate at the left lung base. And she also has an elevated white blood cell count of about 11,000 with 74% neutrophils. So we're going to approach the management of this patient, using the 4 moments of antibiotic decision-making framework, which is the foundation of a lot of the HRQ safety program and may be familiar to some of you already. But this is basically just the idea that as we are deciding to treat a patient with antibiotics and deciding what antibiotics to use and for how long, there are essentially 4 points at which we need to reassess our antibiotic use. So we're going to start with decision point number 1, which is, does the resident even have symptoms that would suggest an infection? And if they do, is it reasonable to treat those symptoms and actively monitor them before we make a decision about starting empiric antibiotics? So going back a little bit to our bronchitis versus pneumonia distinction, clinically, the presentation can be very similar. The symptoms she's describing could work with both, but the fact that she has a chest x-ray which shows a new lung infiltrate does suggest that she likely has pneumonia and not bronchitis. And because pneumonia is typically a bacterial infection, in this case, it's likely going to be reasonable to go ahead and start her on some empiric antibiotics. So now that we've decided that she seems to have pneumonia, we need to think about what diagnostic test we should send to help us when we're determining the choice and duration of antibiotic therapy. And once we've gotten all our diagnostic testing done, we need to think about what antibiotics or other empiric therapy should we start. So some of the diagnostic tests you are likely going to want to send in a resident with suspected pneumonia are here on this slide. A sputum culture with gram stain can be very helpful when it is collected appropriately, which can be challenging in skilled nursing facility residents. It's important to emphasize to the resident that they should be trying to cough up a deep mucus sample and not just spitting into the cup in order to give a good quality sample and avoid a false positive result overgrown with common respiratory bacteria. This can be hard to do if the patient's not really able to follow direction very well, or if they're not producing a lot of sputum, in which case maybe you might want to avoid this test. If you are able to send a respiratory viral panel or a respiratory pathogen panel that includes viral and viruses and bacteria, this can be really helpful because the turnaround time is going to be much faster than culture. It's also going to be more sensitive than culture. The trade-off of that is that can also produce false positive results, and particularly in the case of viruses, can turn up some patients who are colonized rather than truly infected. It's also going to be more expensive. I don't think I need to emphasize to anyone the importance of testing for COVID-19 right now as we weather our pandemic, so I'm not going to spend much time on that. But I am going to talk a little bit about urinary antigen testing for Streptococcus pneumoniae and Legionella. So as I mentioned before, Streptococcus pneumoniae is one of the most common causes of bacterial pneumonia, particularly among elderly patients in the community. The urinary antigen test has several advantages in that it's going to be much faster than culture, and also Streptococcus pneumoniae can sometimes be a little bit difficult to culture. So this can help you capture some patients who are not able to provide a sputum sample or for whom the sputum sample doesn't grow. Legionella is another important bacterial pathogen to consider. It is one of the most common causes of quote unquote atypical pneumonia, and particularly in elderly patients can cause quite severe disease. It also tends to be seasonal, more common during the summer and fall months, but can be seen in outbreak settings at any time of year, particularly in acute care or post-acute care settings. Sometimes antigen testing is not available in post-acute facilities because of the cost or other difficulty with, obtaining the materials or send out to the correct lab. If it's not available at your facility, it might be worth looking into whether there's way to change that because these are extremely helpful tools when it comes to antibiotic management and antibiotic de-escalation. So for a patient who's at relatively low risk for infection with a resistant organism like Mary, your mainstay of treatment is typically going to be a beta-lactam antibiotic, such as amoxicillin clavulanate, aka Augmentin, or for a patient with mild penicillin allergy, you might consider an oral second or third generation cephalosporin, like cefpidoxime or cefdinir. If the patient's not able to tolerate PO antibiotics, you could use something like ampicillin sulbactam, aka Unison, or an IV second or third generation cephalosporin like ceftriaxone. You also want to be sure to add coverage for atypical bacteria like Legionella until those pathogens have been ruled out. Azithromycin can have some cardiac conduction effect, particularly QTc prolongation. So if you have a patient who has already known cardiac conducting system disease, doxycycline may be a better option. For a patient who is known to have a moderate or severe penicillin allergy, your go-to option would likely be levofloxacin. This is not only not related to penicillins, but has the advantage that it also has excellent coverage for atypical bacteria. So it can be used as a monotherapy. You don't have to combine it with azithro or doxy. Just to talk briefly about patients with penicillin allergies, these are extremely common. About 10% of adults in the United States report having a penicillin quote unquote allergy. And when they say allergy, they could be referring to any number of things, including reactions that we would classify as intolerances, not true IgE-mediated allergies, which includes isolated GI symptoms like nausea or diarrhea, headache, itching in the absence of a rash, or yeast infections. If you have a patient with one of these intolerances, there is likely going to be very minimal risk to beta-lactam therapy. And instead, you may want to consider just providing adjunctive treatments to manage any symptoms that may develop during the course of treatment. If you have a patient who had a laboratory abnormality associated with penicillin, like AKI, elevated LFTs or other LFT abnormalities, QT abnormalities, or C. difficile infection is sometimes classified in this category, there's not really a hard and fast rule. You're going to have to make a determination on a case-by-case basis, considering the severity of the reaction, how likely it was that penicillin was the actual cause. It may be reasonable to use a beta-lactam, or you may want to avoid it for safety's sake. Low-risk allergies are going to be your delayed maculopapular rash. That is a diffuse, typically flat or minimally raised reddish rash that is non-pruritic. These patients can usually be treated with a related beta-lactam, such as a cephalosporin, with no issues. So it's not a reason, to avoid using a cephalosporin or other beta-lactam antibiotic. Medium risk allergies include severe maculopapular rashes that are severe enough to require hospitalization, or hives, which is going to be a raised, rounded, highly pruritic rash. So in those patients, you probably do want to avoid treatment with a beta-lactam, including a second or third generation cephalosporin. But it's good to consider sending them for an allergy evaluation in order to avoid excluding beta-lactam therapy as an option for them at all. It's been well documented that patients who are not able to be treated with beta-lactam antibiotics and therefore have to use suboptimal or broader spectrum agents have higher risk of treatment failure and infectious antibiotic-related complications. For example, resistant infections down the line, and in particular, C. difficile infection. Patients with high-risk allergies like a blistering or desquamating rash, concerning for Stevens-Johnson syndrome, or toxic epidermal necrolysis syndrome /TENS, or patients who have had anaphylaxis to penicillin in the past, of course, should not be treated with a beta-lactam antibiotic. But again, it can be very useful to involve allergy in evaluating these patients. Because it's been well described that 80% of patients who have a true IgE-mediated allergy, even a severe allergy, will lose this allergic response after about 10 years. So even a resident who had anaphylaxis as a child might be able to safely get a beta-lactam antibiotic in their 70s. So for residents who are at risk for resistant infection, again, this is going to be your residents who were hospitalized or treated with broad-spectrum antibiotics in the past 90 days, who have a history of resistant infections or structural lung disease, etc. You probably do want to start empiric treatment with an anti-pseudomonal antibiotic, such as cefepime or piperacillin-tazobactam, also known as Zosyn. If the patient has a known history of prior MRSA infection, or if you have data about very high MRSA colonization rates at your facility, and in particularly in a resident who is quite ill, it may also be reasonable to cover empirically with an anti-MRSA antibiotic, such as vancomycin or linezolid initially. These patients should also be treated empirically with azithromycin or doxycycline, because quote-unquote atypical pneumonia, in particular Legionella pneumonia, can still cause quite severe disease. And if you have a patient who has a known moderate or severe penicillin allergy, levofloxacin plus or minus an anti-MRSA agent like vanc or linezolid is probably going to be your standard empiric care choice. So in the case of Mary, after looking at the chest x-ray, the on-call healthcare practitioner overnight starts her on a 10-day course of levofloxacin without sending any other testing. But fortunately, the daytime provider does remember to send off a flu swab and a urine pneumococcal test in the morning. So while we wait on the results of those diagnostic tests, we should think about how long we want to treat this resident with pneumonia. So in the past, a 10-day course of treatment was kind of de rigueur, the sort of standard of care for patients with pneumonia. But there's been increasing evidence over the years that shorter durations of antibiotic therapy not only lead to equivalent outcomes for patients, but are also much less likely to lead to adverse events like allergic infections or allergic reactions or C. diff infections. For the majority of residents, a course as short as 5 days of antibiotics will likely be sufficient to treat a bacterial pneumonia. That being said, if a patient is slower to respond to therapy, not improving so much after the first couple of days of treatment, that's a patient that you might consider extending treatment course to 7 days, or again, even potentially longer. You know, these recommendations do need to be individualized to some extent. But 10 days of therapy as a starting goalpost is going to be longer than is appropriate in this case. So Mary's urine pneumococcal antigen test does come back positive. So we think that she has pneumococcal pneumonia. In this case, what should be our next step in management? Do we want to continue her on levofloxacin? Do we want to stop levofloxacin and switch her to amoxicillin? Do we want to stop all antibiotics, or do we want to transfer her to the hospital? I will give 30 seconds to a minute. Okay. Since we're getting close to 1 o'clock now, I'm gonna just go ahead and reveal the answer, which is to switch from levofloxacin to amoxicillin. So Streptococcus pneumoniae in general is extremely susceptible to penicillin. A 2017 study by the CDC found that greater than 95% of isolates were susceptible to penicillin and by extension to amoxicillin. Levofloxacin will also cover Streptococcus pneumoniae, but it is a much broader spectrum agent than amoxicillin. It has a lot of potential side effects, including much higher risk of C. difficile infection, QTc abnormalities, In elderly patients, it has also been described as a cause of, or more likely to cause encephalopathy or delirium. So amoxicillin is the better choice. We don't want to stop all antibiotics because we're treating her for pneumonia. And at this point, she's quite stable, so there's no reason yet to transfer her to the hospital. So we might want to consider transferring a resident with pneumonia to the hospital if they're not showing any clinical improvement within 24 hours of starting antibiotic therapy. And if, of course, they are initially clinically unstable, for example, unable to maintain a stable oxygen saturation or hypotensive or tachycardic concerning for sepsis, then they should be transferred to the hospital sooner rather than later. So moving on to our last case, Francisco. This is a 92-year-old bedbound gentleman who's a resident at your skilled nursing facility. He has multiple sacral and other pressure wounds and does have a history of pressure ulcer infections in the past, including pseudomonal pressure ulcer infections. So his daytime nurse notes that when she was feeding him some applesauce earlier in the day, he choked while he was trying to swallow, and afterwards he was coughing a lot. And then later in the evening, his nurse notes that he's coughing even more, and now his oxygen saturations have been dropping.
The guy didn't come back?
She's been having to put him on oxygen intermittently. So it's a Friday. The provider covering is worried that if Francisco gets worse over the weekend, it's going to be really hard to get a chest x-ray, and so wants to go ahead and get a chest x-ray now. It's worth noting that in these situations, it's not necessarily recommended to get a chest x-ray up front. Rather, it's perfectly safe to monitor these patients for a day or two to see how they're doing. But in any case, we do get a chest x-ray, and we see that he has a new consolidation of the right lower lobe, a very classic location for aspiration pneumonitis or pneumonia. So aspirated contents are typically going to go down the right and brainstem bronchus, which is shorter and straighter than the left. Typically, if the patient aspirates while upright, it's going to be a lower lobe infiltrate, and if you're lying down, you might instead see a right upper lobe infiltrate. We also get a, I'm sorry, could everyone please make sure they're muted?
This is very interesting. No, it's finished now.
So he also has an elevated white blood cell count of 12,000. So just to review a little bit the differences between aspiration pneumonitis and pneumonia. Pneumonitis is chemical lung injury from stomach or upper respiratory contents actually causing inflammation through the lung tissue. Pneumonia can progress from pneumonitis and is actual invasion and infection of the lung tissue with bacteria. Patients with aspiration pneumonitis may be completely asymptomatic, or if they have symptoms, they're typically going to develop fairly quickly within 2 to 5 hours after the aspiration event. And they should also start to improve pretty quickly, typically within 24 hours, but certainly within 48 hours. They may have a low-grade fever, but it shouldn't be persistent as compared to a patient with aspiration pneumonia who's going to have persistent cough, persistent fever, persistent tachypnea, or hypoxia sometimes. The treatment for aspiration pneumonitis is really, number one, to place the patient on precautions in order to reduce the risk of future aspiration events, and also to actively monitor them for any evidence of clinical worsening, whereas a patient with pneumonia does require treatment with antibiotics and potentially with respiratory support if the infection is severe. So in the case of Francisco, what is going to be the next best step in management? Do we want to start him on some levofloxacin? Do we want to obtain sputum culture, urine Legionella pneumococcal antigens, transfer to the emergency room, or put him on speech and swallow precautions and monitor him for the next 48 hours? We have a vote for start antibiotics. Okay, so we have some votes for start antibiotics and to do some additional workup with sputum culture and urine Legionella and pneumococcal antigens. So in this case, Because Francisco had a witnessed aspiration event, and importantly, because he is for the most part pretty clinically stable, requiring a little bit of oxygen, but not hypotensive, not febrile, it's reasonable to put him on speech and swallow precautions and actively monitor him over the next 48 hours, because it's very likely that he has aspiration pneumonitis. There is no evidence that starting antibiotics for a patient with aspiration pneumonitis reduces the risk of progression to pneumonia. And at this point, he doesn't necessarily have strong evidence of a bacterial infection at this time. If he does later develop evidence of pneumonia, it would be good, for example, if he's not improving after 48 hours, or if he starts to get sicker before then, if he's febrile, if his oxygen requirement is increasing, we would want to do some additional workup and start an antibiotic. The choice of what antibiotic to start would depend on what we know about his allergy history and antibiotics exposures. However, in this case, it would probably be reasonable to start treatment with a broader spectrum antibiotic, for example, cefepime, since we know that he has a history of multiple prior infections with Pseudomonas in the past. But if he did not have that risk factor, starting treatment with something like Unison or even Augmentin, as long as his swallowing can be monitored safely, would be appropriate. I do want to just mention briefly a little bit as well about the approach to diagnosis of pneumonia in patients with chronic ventilators. This can be a little challenging because depending on the resident's ability to communicate, you might not be able to rely on some of the subjective findings that another resident with pneumonia may describe. But you should see some of the other objective clinical findings as you would expect in a non-ventilator dependent patient, such as fever, an increased oxygen requirement, or increased pressure support requirement, and new chest x-ray findings you would also expect to see. Obtaining culture data can be very challenging in these patients because tracheal aspirate cultures are virtually always going to be positive in a patient who is chronically on a ventilator. Studies in ICU patients have shown that being intubated on a ventilator for as little as 48 hours is enough to significantly alter one's respiratory flora to the point that you become colonized with organisms that would typically be considered pathogens. So it's important to keep in mind that a positive tracheal aspirate culture in isolation does not require treatment and does not necessarily indicate the presence of pneumonia unless you have the other clinical findings that go along with it. And whenever possible collecting a tracheal aspirate culture, it's important to use a sterile culture to obtain the sputum rather than the inline suction, which is also going to be heavily colonized with the patient's flora and also environmental bacteria, and is not necessarily going to provide you the most accurate results. Whenever possible, it's also best to have the sample transported to a microbiology lab within 2 hours, although obviously this can be very challenging, particularly if the sample is collected after hours or on a weekend. In those cases, making sure that the sample is refrigerated can help avoid overgrowth of environmental bacteria and preserve a better culture for further diagnostic testing. So just to summarize, in patients with suspected pneumonia, making sure that you obtain the appropriate diagnostic testing can help you confirm whether you're dealing with pneumonia or another clinical mimicker, and crucially can help you target antibiotic therapy down the line. For most patients, 5 to 7 days of antibiotic treatment will be sufficient, although of course this should be evaluated on a case-by-case basis if a patient's not improving as expected. And antibiotics are not always necessary for people who have aspirated. Patients with aspiration pneumonitis will typically see resolution of their symptoms within about 48 hours, even if no antibiotics are offered. However, if you're monitoring a patient and after 48 hours their symptoms are not improving, that would be the point when you want to do some diagnostic testing for pneumonia and potentially start antibiotic therapy.